Hello and welcome. I'm very excited today to introduce a educator that I've been following for quite a long time. Ruth Werner is going to be my guest today. Hello, Ruth. How are we doing?
I'm very well, Aubrey. How are you?
I'm good. I really
Good.
appreciate you joining us. I've been familiar with your work probably since about the mid to late 90s. Obviously, your pathology book has been a staple for massage educators, for therapists. We've used it all the time. We've followed you through several editions as you've progressed and grown and developed this. One of the hardback ones that we have of yours, I think it's like the sixth or seventh edition, is absolutely my Bible when it comes to pathology. And I always say to students, it's not just about learning pathology like you would from an anatomy book. The big advantage is that it is for massage therapists. I mean, it's there in the title, but I love the way you describe a condition. You have synopsis as well. So if somebody's in a hurry, if somebody's come into the clinic, you can have a quick look. What's this condition? Is it safe to work? You know, that's the core things that I need to know as a therapist. But then you also have great depth when they have more time to go and examine that and have a look at it. So we always say to students, this is a book you must have on your shelves. And we've been saying that for a couple of decades. So I was delighted to finally get to meet you in person in Oklahoma this year. You were teaching a session there as well?
During those breakout sessions, we had a little get together, and everybody who wanted to talk about COVID and long COVID came and spent some time with me, and that was really fun.
Yeah, because it is an issue that a lot of therapists, I think, are seeing now. I know different parts of the world are at different stages in their response. For a lot of the world, certainly here in Ireland, all restrictions have lifted. A lot of people have that mindset of COVID is over as far as we're concerned. There's no requirements for masks or any of those kinds of things. Obviously, you're still maintaining the highest health and safety standards in your clinic room. But what we are seeing is clients coming in with that kind of post-viral fatigue, that long COVID. So I believe that's the subject of your talk today.
Yes, you and I chatted about what might be most useful for your folks. And so what I've done is I have distilled quite a long class, a 3-hour class on long COVID, into what I hope will be in the neighborhood of about an hour, with an invitation for you to interrupt me and make sure that I'm speaking to your audience, because I haven't really, spoken to people in Ireland about anything
Yes,
to do
yes.
with pathology. So, I may be unaware of things that'll be of special interest to you.
That's great. Hopefully, there's things that I might pick up on that some of our viewers and some of our students, our past graduates, may be interested in. So I'm really interested in jumping into the discussion.
Before we get going, there's just a couple of things I would like for our viewers or listeners to know. One is I'm doing this from my home, and I have a puppy. And so there is a possibility there might be a little noise. And if she comes close by, I might, show her off a little bit.
Introduce her, yes.
Yes. And the other thing is, and I have to give this little disclaimer every time I speak, I live with a chronic cough, and it has been diagnosed as a neurological issue. I'm not sick. I don't have COVID. But it's 8 o'clock in the morning for me. And so it's my first sort of talking of the day. And so I may cough a little bit, excuse me. Having a microphone in my face is a little bit of a trigger. So it's nice to get that out of the way so that people don't worry about me.
Good, good.
So I'm so glad to be with you and to talk about long COVID. And I know when I speak in the States, most people are familiar with me. They know my work. And so I don't have to do a lot of orienting to the way that I talk about things, but that's not necessarily true for this audience. So this is how, when I am writing and teaching about pathologies, this is sort of how I break things down. So in our time together, we're going to just do like a 1 or 2 slide overview of what we understand about COVID-19. And then when we look at long COVID, this is the way I go through the process to make sure I've covered all the most important information. So we'll be looking at these things: definition and demographics and pathophys, signs and symptoms, which is going to be a treat, treatment and medications, which is not much. And then a quick run through a critical thinking rubric or critical thinking flow that I have developed that I think is really helpful for massage therapists to figure out risks and benefits about working with people with disorders, not just long COVID, but really anything. The other thing that I've provided for you in this slideshow, and I've given you a link to where you can get it, is what I think was a pretty good list of screening questions for clients who have long COVID. So we may not go through that in detail, but I've given it within the slideshow, there's a link, and Aubrey, I can get that link to you as well.
Perfect. Thanks, Ruth.
So as I was preparing for today, I went and, just updated our statistics. As of the 12th of September, that's today as we are recording, right now worldwide, according to Worldometers, which is a decent source of information about this, we've seen a little over 613 million diagnoses of COVID and 6.5 million deaths from COVID. And then I looked at the statistics in Northern Ireland and found that you have seen about 713,000 diagnoses and about 3,400 deaths. And I did not include a picture of this, but I saw on the bar graph for Northern Ireland that your numbers have come way down and they have stayed down. And I just want to congratulate you. It would be it would be nice if that were the case in the United States. It's not.
Yeah.
And as you mentioned at the beginning of our talk today, we have this little bit ridiculous idea that we're done with this infection. We are not done with this infection. The current viral variants that are active appear to create less virulent infections, but the risk of long COVID has not gone away. Before we start talking about long COVID, I just want to give you this much of a reminder. Some of our listeners may be, terribly familiar with this, either because you've been through it or because you've been following COVID-19. But basically, in a nutshell, here's what we understand about this virus. The name of the virus is SARS-CoV-2, Severe Acute Respiratory Syndrome number 2, coronavirus 2. And what it does is once it gets in the body, which is usually through the respiratory system, it particularly targets and attaches to cells that have a marker on the cell membrane called an ACE2 receptor. Mm-hmm. And the problem with this, the reason this is bad, is that we have an enormous number of cells with ACE2 receptor sites. We have ACE2 receptors on our myocardial cells, on our renal cells, on our hepatic cells. We have ACE2 receptor sites inside the GI tract. And here's the kicker. We have ACE2 receptor sites in the lining of our blood vessels. So if you remember the endothelial lining of our blood vessels, those have ACE2 receptor sites. This virus can invade the blood vessels. It can invade the central nervous system. It can invade the heart and the liver and the lungs and the kidneys, because we have ACE2 receptor sites just all over the place. And that's one of the things that has made this virus so dangerous. When we have a viral infection, if you think about an upper respiratory infection like cold or flu, typically what happens is the virus gets in the target cells. The target cells wave a white flag to say, help, help, I've been invaded. And then immune system cells come and they kill the infected cell and also all of its neighbors, just in case they were infected as well. And this is what causes a lot of our symptoms when we have a cold or a flu, is less from the virus and more from our immune system responses against it. And that's normal and healthy. And all those cells that we just killed off, they grow back pretty fast. And that's great. But for some people who develop COVID, in addition to damage from the viruses attacking all of those ACE2 receptor positive cells and the immune system killing all the infected cells and their neighbors, what some people seem to have developed, and you'll remember this early in the, 2 years ago when we were first trying to wrap our heads around this thing, we saw some people would get really, really sick. Some people would get really sick and die. And the key difference appeared to be who gets this crazy, completely out of whack, out of proportion, outsized inflammatory reaction. And that finding led to treatment strategies for acute infection that became, quite successful. We've been reveling, we've been dancing in the success of our vaccines, which have been miraculous. But the unsung hero in this pandemic, I believe, have been the people who have figured out ways to treat people who are already sick, for whom it is too late to get their vaccines, and to create a strategy that introduces the right kinds of anti-inflammatories at the right moment so that you get maximum benefits and minimum, whatever. So our survival rate from COVID is much, much, much better than it used to be because we have come to this understanding about this inflammatory response. What we're left with now, of course, is this post-viral syndrome that has not gotten, in my opinion, has not gotten appropriate attention. There was a hot minute between when the initial virus subsided and the development of Delta, when our attention shifted for just a moment and we started paying attention to the people who had gotten sick and were still sick 6 months later, or who had gotten sick, appeared to get better, and then developed whole new syndromes. And we began to pay attention, and then we got whacked with Delta, and then we got whacked with Omicron. And so those people sort of fell off the radar. Now that our hair is a little less on fire about acute infections, we are beginning to pay attention to long COVID, but there are still an enormous number of unanswered questions. So I was actually recruited by a publisher in Edinburgh to write a book on massage therapy and long COVID. And I laughed and laughed and laughed and said, let's talk in 5 years. Because our understanding of this is in its infancy, and it is perplexing us at every turn. So before I launch into this bit of the presentation, Aubrey, I just want to check in any questions or pushback or differences of opinion about things.
No, I think that makes sense, that a lot of people didn't really know what was going on in the early stages. And I think that was caused a certain amount of churn for a lot of people, where advice changed and things like that. And I think if you were following it, you'd understand that it is a development of understanding as we progress through the disease, and also then as variants start to arise, that causes a lot of change in approach and advice and things like that. And I think you've covered that nicely. Thanks, Ruth.
Oh, you're welcome. And I'm happy to do that. And you've pointed out a really interesting thing, which is as a as a population, we want, and we're scared about this new infection. We want some answers, and we want for those answers to stay true. Mm-hmm. And it becomes really, it becomes frightening, and that fear turns into anger when those answers shift and change.
Yeah.
We had these wonderful vaccines. The vaccines are less effective against Omicron. They're still really effective, but they're less effective against Omicron. We thought people could only get sick once. People have been getting sick over and over again. It's a moving target. And as a population, we need to understand that this is a moving target. And so, and especially as healthcare providers, our job is to give the best and most accurate information that we can, with the caveat that may change.
Yeah.
And as a pathology educator, that became the entirety of my job, in the first 2 years that we were living with this challenge. All right, let's talk about long COVID. I know, let's talk about long COVID. So the definition of this thing is unclear. It is obviously it is a post-viral syndrome. COVID is not the only infection that creates a post-viral syndrome. We have seen post-flu syndrome. We have seen many people consider that, at least for some patients, what we call chronic fatigue syndrome and what you probably call myalgic encephalomyelopathy. Mm-hmm. Do you want to say that with me? Myalgic encephalomyelopathy.
Yes, I agree.
Or ME.
Yeah, me,
Um,
exactly. That is interesting that I think, I don't know what your opinion is on this, is part of the reason that maybe long COVID didn't get very much attention is because it's varied, it's not predictable, the symptoms are different. I'm thinking of the likes of fibromyalgia, where there's still contention of, is it a syndrome? Is it because it wasn't easy to define? Is that partly why it didn't receive very much attention?
yeah, well, it received attention, but no answers, and not a great deal of interest from the scientific community, and the medical community was really, up to their eyeballs in trying to get people to survive.
Yeah.
After that, that seems like a lower priority, and then now we're able to shift our priority because the death rates from COVID have come way down.
Mhm.
And as you say, the symptoms are so variable, and we're going to talk about this in just a moment, that it can be difficult to play out who has ME versus who has long COVID versus who has fibro versus who has something else.
Mhm.
Are they faking it? Are they making it up? Are they,
Is it in their head?
is it in their head, right?
Yeah.
Which in a weird way, it sort of is, and that doesn't matter.
Mhm.
So it's a little bit, I have a handful of diseases that I call the tomato seed diseases, which means the harder you try to grab it, the further away it squirts.
Right.
Right. And long COVID is in there along with chronic fatigue or ME and
Mhm.
fibro and a few others. And one thing they have in common is in many cases, they appear to be post-infectious syndromes. Chronic Lyme disease fits in this category,
Okay.
post-sepsis syndrome, and both of those are post-bacterial infections rather than post-viral.
Yeah.
But the pattern is the same. Someone has an acute infection, they clear out the acute infection, and then they get hit with a lot of unexpected and nebulous and hard to pin down things that can range from being really annoying to being disabling.
Yeah.
And they deserve our attention and our care, but
Mhm.
it's hard to provide that if we don't know what it is. So one
Yes.
of the really frustrating things about trying to talk and teach about long COVID is we do not have a well-established diagnostic criteria. We don't know if we're talking about people whose symptoms have persisted for 3 months, people whose symptoms have persisted, or sometimes, as I said, the symptoms can subside and then new syndromes seem to emerge and they persist at 6 months or at 9 months. What is the cutoff point between when it's just a long healing process and long COVID?
Mhm.
How do we tell the difference between this and ME and fibro and other things? Is there a difference? So until we have a diagnostic criteria, it's going to be really hard to make a lot of declarative sentences about this.
Yeah.
One of the things that the medical community here, at least, and I did not do research to see what your national health system is saying about long COVID. So I'm sort of, I'm stuck in my little bubble. But we are now talking about delineating between an acute COVID infection with a really, really long recovery period
Mhm.
and a new post-infection syndrome. And that very long recovery period can be related to several things, and there's no reason they have to be separated. We have seen that COVID attacks the heart and the liver and the lungs and other organs. And, if that damage is permanent, that for some people, that's what long COVID is. It's heart damage, right?
Yeah.
It's lung damage that can go to pulmonary fibrosis and other things. So it could be related to damage to organs. We also see that people who are hospitalized for prolonged periods end up developing complications related to just having been hospitalized, having been tranquilized, and then they get this weird, it's a form of post-traumatic stress syndrome called PICS, which stands for post-intensive care syndrome. And then, of course, muscle weakness because of atrophy and having been bedridden, brain dysfunction because of the drugs and everything else. So we see, and one of the things we see is that people who have very, very severe infections with COVID that involve hospitalization are at higher risk for long COVID than people who had less severe infections, but that's not a one-to-one correlation.
Yeah.
There are lots of people who have mild initial infections who develop very, very severe post-COVID. So, there's not a lot of declarative sentences to make here.
Yeah.
So we don't know, because we don't have a diagnostic criterion to say this is long COVID, this is not. We don't know how many people have it. Yeah. A research team led by Logue et al. Found about 30% of patients had symptoms at 9 months after their infection, and a third of those people had no symptoms at their first COVID test. So these aren't all severe cases, but this was based on the Delta variant and previous. This does not reflect Omicron.
Okay.
A paper I looked at yesterday, although I did not read it in detail, suggested that the rate with Omicron infections appears to be lower, maybe 4 to 5%.
Okay.
4 to 5% of many, many millions of people is
a lot of people.
A lot.
It's funny because it seems just anecdotally, I would have thought that figure was a lot lower. 30% is really surprisingly high, isn't it?
Really, really high.
Yeah.
I agree. I agree. And, just from my experience, I know lots of people with long COVID.
Because I was going to say, I think I've only
I
met
don't think
one.
It's 30% of all the people who got infected. But this was what Logue et al. Found with the criterion of having some kind of symptom. And that symptom might be just fatigue or shortness of breath or, something mild. They didn't delineate in this paper between very severe long COVID and mildly annoying long COVID, right? Yeah. We see that vaccination offers some protection from long COVID, but not full protection. One podcast with public health experts that I heard suggested that people who are vaccinated develop long COVID at about half the rate of unvaccinated people. And as we mentioned a couple of minutes ago, the risk of long COVID is somewhat tied to the severity of the infection. But again, people with very mild infections also can develop this syndrome.
Not a direct correlation. Yeah.
Right. This is where in a normal pathology conversation, I would talk about pathophysiology, right? What are the changes that make this thing happen? And the truth is we have no idea what makes long COVID happen. We have lots and lots of theories, and this is the short list. And this is a list that's constantly evolving. I want to say that as well. And again, and there's crossover between these things. These are not distinct phenomena. They can be parts of each other or freestanding. Yeah. But, here are some ideas. We have seen that for some people who have long COVID, they have colonies of virus that have found a way to linger and hide in their tissues. And so they continue to launch an immune system attack against us. And this is similar to some thoughts about ME, that there was an exposure to Epstein-Barr virus. The virus lingers because that's its habit. It's a member of the herpes viridae, and we don't expel herpes. Yeah. So, maybe there are colonies of virus that are hanging around.
Do they think that's likely to be colonies of SARS-CoV-2 or prior viral infection, or is there any...
little of both.
A little of both. Okay.
Little of both, because if you look at the fourth bullet down, reactivation of other viruses like the herpes viridae.
Okay.
Yeah. Hi, Gaia. My dog just came to say hi. All right. We do see definitely immune system dysregulation and maybe some autoimmune viral mimicry. So there are some aspects of immune system dysregulation, and some people with long COVID appear to develop new autoimmune diseases, vasculitis, for instance. Wow. And but that's not true for everybody. We have mentioned before that for some people, their version of long COVID may be related to permanent scarring in their lungs, in their heart, in their kidneys. We have seen people develop new onset diabetes, for instance, which, suggests damage to the pancreas, but that also is terribly wearing to the kidneys.
Yeah.
Reactivation of other viruses we mentioned. Dysbiosis. You're probably aware that we have a microbiome in our gut and on our skin, and it's meant to be there and it's meant to be healthy. One thing that I learned in the process of learning about long COVID is we also have a microbiome in our respiratory tract, which makes sense, right? It has interaction with the outside world.
Yeah.
And, long COVID can seriously disrupt the microbiome, both in our gut and in our respiratory tract. And so, what that theory does is it offers some new ways of thinking about treatment or coping. I don't know how you would restore the appropriate microbiome in your lungs.
Yeah, that's a tricky one.
Good question.
Breathe
Almost
in a new
everybody,
microbiome.
yeah. Almost everyone that with long COVID who I have interviewed say that they feel they have inflammation in their central nervous system. And we see this reflected as new onset of headaches and migraines and peripheral neuropathy and, all kinds of symptoms that suggest things are not right in the central nervous system. Microclots is a huge new line of inquiry. We saw it with acute infection. We saw tiny clots forming in the capillaries that will then interfere with blood supply to the organs. Yeah. What we have not figured out how to do is appropriately and safely introduce thrombolysis chemicals that would help us to melt those microclots. Yeah. And the scary thing about this is people who are very desperate are now, seeking plasmapheresis or other really intense blood treatments that are a little sketchy, unproven and possibly dangerous, in order to try to treat their microclots, which may or may not actually be a problem for them. It is a problem for some.
Which falls into that kind of risk-benefit sort of continuum that you've talked about before.
Yes, and when you're desperate, and nothing else works and no one has any answers for you, you're willing to try things that might not be advisable. And I totally get that. All right. Anyway, so this is where we are for trying to understand the pathophysiology of this thing. And it's probably many of these, and each individual person might have any combination of these factors or more that we haven't even thought about yet. So when we talk about the signs and symptoms of long COVID, for the sake of my own sanity, I have divided talking about signs and symptoms into those related to organ and blood vessel damage and those that are more generalized. And so we won't go into these in detail, which is something I would do with the longer class, to look at signs and symptoms related to lung damage and heart damage and kidney damage and so on. Yeah. I do want to point out that COVID can cause permanent scarring in the lungs. There's a particular X-ray artifact or visual cue with long COVID called ground glass opacities. That is, appears to be very, very predictable for people who have COVID. And if it's mild, it may resolve and the person may regain full lung function. But if it is severe, lungs are weird and they can. And one of the things they do that's particularly strange and scary is once the scarring process sort of reaches a point of critical mass, the lungs will begin to create scar tissue spontaneously. Yes. And this is a condition called pulmonary fibrosis. Yeah. It's very, very serious, usually terminal. Mm-hmm. And in the United States, at least right now, the number one reason for people to receive lung transplants, which is a treatment for pulmonary fibrosis, is because of damage related to COVID. So it's one of
That's
the reasons
severe.
it's very severe. I take lung things very seriously just because I live with this cough, right?
Yeah.
Excuse me.
On cue.
The word cough makes me cough. Um, and another reason that I think understanding the idea of permanent lung damage and what that does in terms of shortness of breath and oxygen saturation in the blood is that there are some capacities for massage therapy to be really helpful here with focus on breath work and reducing some of the anxiety that can exist around taking a really, good and fulfilling breath.
Yeah.
Again, we see permanent heart damage. Sometimes it's temporary, but we have seen signs of permanent heart damage even with people who have mild or asymptomatic infections, kidney damage, brain damage, and so on. And of course, coagulopathy, which is problematic blood clotting.
Yeah.
And this can be related to, remember, the virus infects the lining of blood vessels.
Yeah.
When I first learned that, I was appalled. And then I looked up to see if there are other viruses that do that too. And there are.
Okay.
Even flu can do that. But we have never seen anything like this before. Yeah. And when we combine that in that damage to our lining of blood vessels with a really heightened inflammatory response, this is what can lead to the tiny little microclots that cut off blood supply to our organs and the great big macro clots that were leading people to have pulmonary embolism and stroke and heart attack in those early days before we knew how to treat this. And that was a cause of death for a lot of the people who died early in the pandemic.
And I don't want to jump forward. I may be spoiler alert, but are you going to talk maybe a little bit about that in relation to massage? Because I think that's probably what's popping into most people's mind when they start to hear clots as therapists. So
thank you. Oh, I'm so glad to hear that pops in your minds. That it makes me very happy.
Yeah, well, if you're doing any kind of circulatory treatment, which, body work is,
sports massage,
that's got to be a huge concern. It's got to be something you're really focused on. So, yeah, I don't want to jump ahead. I'm sure you're going to get to that, but just thought
I will.
For people watching, it'll come up, I imagine.
Yes, I promise. And in those, yes, okay, good. We will come back to this. So those are the sort of organ-based signs and symptoms. And then we have this long list of more general things. Fatigue. The fatigue can be related to central nervous system issues or low oxygen supply because the lungs are damaged, or low oxygen saturation because of the tiny microclots. I mean, what is the fatigue from? Or all of the above. Shortness of breath, which contributes to fatigue. The brain fog has been a huge issue for just about everybody with long COVID that I have spoken to. That can reflect central nervous system inflammation. Migraine and headache, loss of smell and taste, that can persist. We saw those as early symptoms, but that, I've spoken with people 6-8 months out who still have really, really limited sense of taste. And that's a type of peripheral neuropathy.
I was going to say, I think maybe that's why it may seem a little bit underreported, because one thing you do hear a lot of people say is that they continue to get brain fog and they may not have fully gotten their sense of taste or smell back, but they don't necessarily see that as long COVID.
Right.
If they just have those symptoms.
Yeah. And then there's this whole issue of dysautonomia, which is, problems with appropriate autonomic nervous system responses. And this can lead to a whole bunch of things. Problems maintaining a healthy heart rate. Is that dysautonomia or is that heart damage? Right? Yep. Dizziness, is that central nervous system issues or heart issues?
Yes.
And something that an awful lot of people with long COVID are living with, and it's very hard to manage, is this condition called POTS, or postural orthostatic tachycardia syndrome. Have you heard of that one before?
In passing, I'm not terribly familiar with it, so a little detail would be lovely.
What happens with POTS is when someone changes position, specifically if they are flat and they're coming to sitting, or if they're sitting and they're coming to standing.
Yes.
everything goes haywire with maintaining appropriate blood pressure, and their heart beats very fast. And it may take quite a while for it to come back to normal. And it's terrifying. And it's very, very hard to treat. And we see this with ME. And we see it with fibro. And interestingly, we see it very often with a connective tissue genetic condition called Ehlers-Danlos. What are the connections between these things? It's very odd. But if you look at these signs and symptoms and you take out the loss of smell and taste and maybe the shortness of breath, you can see all of these with fibro and all of these with chronic fatigue syndrome. And it leaves us really, at a loss for how to help people.
Yeah.
Here's a few other signs and symptoms: chest pain, cough, joint and muscle pain. That's important. Is that because of deconditioning? Is that because of tiny little blood clots? Right? Post-exertional malaise, a giveaway for chronic fatigue syndrome. So I've given you a link here to a Facebook group called Survivor Corps. They also have, a freestanding website. It was created very early by a woman who came through COVID and did not develop long COVID, but saw the consequences of this on so many other people. And she sort of created a little community group, and it has exploded. And there are probably hundreds of thousands of members here now. You don't have to have long COVID to join this group. And what I really appreciate about Survivor Corps, and it's not the only one, there are other sort of social media groups for this as well, is it can, if you spend some time here, you really get a sense of what these people are living with. And it's very different from looking at lists of signs and symptoms, because it's easy for us to talk about fatigue and shortness of breath. It's different to see someone describe how they wanted to play with their grandchild and they couldn't, right? Or how they had to give up on a really good job interview because they couldn't get out the door. The consequences of this are very different from a list on a PowerPoint slideshow. And Survivor Corps is a really good place to get the human sense of what this has done to people.
Yeah, I think a lot of therapists see that kind of stuff as well. Fortunately, in the opposite direction, when they see improvement and clients describe things that they are now able to do, day-to-day simple tasks that you might think in terms of increasing range of motion or eliminating pain, but they're thinking, can I pick up my grandchild? Can I get up out of a chair? Yeah, so it's interesting to see that, how is it impacting people day to day in these, tasks that we take for granted a lot, rather than just looking at statistics.
And I really encourage massage therapists, because we are sort of, we are very well positioned to do this. Really, physios are the only other profession that is in a position to do this, is to help our clients really focus on those functional goals. Bending your knee to 90 degrees is a fine clinical goal, but being able to climb a set of stairs without pain, that's meaningful.
Yeah.
Right. Absolutely. And, playing getting down on your hands and knees to play with your grandchild for 20 minutes, that's a meaningful achievement to someone who hasn't been able to do that. So I love to see massage therapists really, and we're going to get to this actually, really hone in on what do you want to accomplish? What would you like to be able to do that you can't do and you think I can help you with? So we're actually going to get to that in just a moment. So in terms of the medical community, trying to figure out a way to treat someone who has long COVID, really what we are left with is if there is specific organ damage that we can identify, we can work on rehabilitating that organ, right? We can work on respiratory therapy to increase or improve lung capacity. We can work carefully with exercises to maybe improve heart function. There is a field of medicine called Autonomic rehabilitation for people with dysautonomia. And it's very, very interesting to me because I was listening to someone describe this, and it is completely within our capacity to do this, because one of the simplest and most effective things they do for people, for instance, who have POTS, is that when they are laying down or when they are sitting and before they are going to move, They are counseled to exercise, to pump their muscles first, right? So before you get up, let's move your arms. Before you get up, let's move your legs. Let's, move your body while you're laying down to begin to normalize blood pressure for movement before we get up. And I thought that was a brilliant piece of super simple, won't hurt anybody, could possibly make a big difference kind of advice for helping people make that transition off the massage table when we have done everything we can to drop their blood pressure.
True.
Right? Before you go home, let's do a little bit of action.
Yeah.
Right.
And I think that's good to think of that it's you're thinking about it in clinic rather than somebody in a home setting, getting them off the table. Really good.
Exactly. I mean, because it's better if people don't fall down once they stand up off our table.
Yes.
Yeah. Physios will sometimes talk about teaching pacing in terms of, setting some exercise goals and then gradually adding to them. That can be problematic if the organs simply aren't going to keep up with it, or if the nervous system isn't going to keep up with it. So I'm a little bit concerned about pacing, just in terms of unrealistic expectations. And then, we have this whole new open question mark about addressing coagulopathy. And I think, that's a point of focus for many in the medical field right now. It's a watch this space kind of key. Yeah. But there are questions about coagulopathy in the screening questions that I'm going to share with you before we're done here. And beyond that, really the medical community is looking at long COVID through the same lenses as we look at chronic fatigue, ME, and fibromyalgia. And these are people who have been abandoned by the medical community. They've been gaslit. They've been told it's all in their head. They've been told to stop faking it. And so, the relationships between the medical community and people who have these chronic pain issues is often not good. And they come to massage therapy because maybe we'll take them seriously. And I think that there's an enormous capacity for help that massage therapists can offer people who have long COVID. And that's our next topic. So any other questions before we go to the next thing?
No, it just what strikes me is, like you said, the similarity with things like fibromyalgia and ME, and how often we see those types of clients in clinic, and we can certainly do a lot to help them. So it's interesting to start to look at things from that perspective, more as a chronic fatigue type condition rather than something in isolation. We look at the commonality with those things and the success that therapists can get. And as you said, I think a lot of these, particularly I see with the fibro clients, because they see it as a physical condition, surely a physical approach is going to work best for them. And I've certainly seen great results with gentle treatment, which is always difficult with the fibro guys because they want you to dig in and go heavy because they think it's tight muscle and it needs to be worked out. And sometimes getting that buy-in from them, the acceptance of a treatment approach, can be a little bit of a challenge. Not so much with ME or the other kind of conditions, but I see it a lot with fibromyalgia clients.
Isn't that interesting? I am actually just wrapping up today a feature article on fibromyalgia.
Ah, interesting.
And the challenges of working with clients who have fibro, because they do present some special challenges. But yeah, let's return to our topic.
Yes,
returning to our topic. I mean, but you make a good point, which is that ultimately, when we look at this at the symptoms and the things people wish were different about their lives, the main difference between people who have long COVID and people who have fibro or CFS or ME is issues around shortness of breath and the risk of coagulopathy. And if we can deal with those things, we can probably offer some really good, effective, and safe treatment. So this is a little critical thinking rubric that I developed specifically for making decisions about working with people with diseases or disorders, and we want to be sure that we're safe. And it is based on about a dozen or more other people's critical thinking rubrics. And I just, I sort of picked and chose and made my own little thing. It's not the be all and end all of critical thinking. It's just a process that I recommend people go through in order to make sure that they've done the best they can. And the thing I want to point out about this critical thinking rubric is it is iterative, and you keep going back to it and you keep adding to what we understand. So we're going to go through each of these steps and this is where, this issue of identifying or analyzing what is it that this client wants and needs out of this session. What is it that this client wants and needs out of the series of sessions that we're going to do together? Understanding that can change, right? So because today it might be my back is killing me, but over the long run, it might be I would like to be able to run a 5K.
Yeah.
Right.
Yeah.
So
which is a good thing. We have
to balance those things together.
If the person's goalpost is moving, it means you're getting progression with them. They're seeing improvements. So that's a good thing. Yeah. Yeah.
And that's a really important thing that we can reflect, right? Lots of times people who live with chronic issues, especially issues around pain and fatigue, is they can forget that they have actually made some progress.
Yeah.
Because we get very closed into what we consider to be a negative experience. And our massage therapist can help us realize, oh yeah, I didn't used to be able to do that.
Yeah.
In any case, so the first step in any massage session or any new massage relationship is analyzing what does this client really need that I can help with. Because sometimes they're coming to us for needs that maybe is not within our scope of practice or maybe is not within our skill set. They may need to seek out that desire somewhere else. But our first step is to figure out what they really need. And it with someone who is dealing with long COVID, then that might look like, I need to not have a headache for an hour. I need to be able to climb a set of stairs without running out of breath. I need to, whatever. That's going to be different from one person to another. But the clearer an idea we have of what our clients' win would be, right? What's a win? My favorite question for this, I had a dear friend ask this once before I got one of the best massages of my life. He said, a win for you today would look like, and he had me fill in the rest of that sentence. And that was great. And he gave me exactly what I needed. It was awesome.
That's a nice way to phrase it as well. A win for today. Because I think that's something therapists don't always focus on, is a short-term and a long-term goal. Because I always like to see, well, ultimately, where would you like to get to? But where would you like to get to today? Because if you just look at the long-term goal, it may take too long to get there and they may get slightly disenfranchised and not continue therapy. So it's always good to have, well, what would we like today at the end of the session? What would you like to have be better or improved or whatever it might be? Manageable goals.
Yeah, and realistic ones for sure.
Realistic.
The hardest part of this critical thinking rubric, in my opinion, is identifying the variables, right? What goes into making decisions, especially around safety. So I made a list of the key variables in dealing with people who have long COVID, which would include, is there organ damage? That's very relevant for our choices. Do they have coagulopathy? Also, obviously, really relevant about massage. What meds do they use and what side effects do those medications cause? This is a very under-addressed issue in most people's education. Yeah. Including mine. What are their activities of daily living, right? What can they do easily and without pain? What happens when they overdo it? What kinds of stimuli are irritating? These are all things that are going to help us create a session that's going to be really safe and hopefully effective.
Now, I think maybe a therapist question there would be, is the client going to be aware if they have organ damage or if they have coagulopathy? Presumably, if it's severe enough, they'll have a diagnosis, I would imagine. Would that be accurate, Ruth?
Yes, absolutely.
Okay.
Yeah.
And if they don't...
So, what you can add to this then is, are you under a doctor's care, and what does your doctor say about your situation?
Yeah, because that's what I'm thinking. If they, with a lot of conditions that we would say, you need to identify the risk factors, something really common like asthma, you'd say, well, there's a big difference treating somebody who has really well managed symptoms. Their medication is working as it's supposed to. They don't have any other complicating factors. They're very safe, versus somebody who has a condition where the medication maybe isn't yet controlling symptoms. There's more variation in the severity of their symptoms, any of those kinds of things that would give you more cause for concern. So would it be true to say somebody they may have these mild things that aren't severe enough for a diagnosis and then could potentially be reasonably safe? Like, I always think if something's bad enough to be a negative factor, they probably know about it. They probably had a diagnosis. They probably have more information they can give you that their doctor has given them. Would that be accurate?
That is absolutely accurate. And one hopes in any case, and if someone comes in and they have not seen a doctor and they're presenting with what you consider to be pretty severe symptoms,
yes,
this is a great time to refer out and say, for your safety, we need more information before we can proceed.
Yeah. If in doubt, refer out.
Yes, exactly right. And I do want to make a delineation between referring out to get more information and asking for a doctor's permission to do our work. And I don't know if that's an issue where you are. In the US, and this drives me crazy, really, I'm having to fight to not have swear words come out of my mouth. We have massage therapists who feel like you need to ask for a doctor's clearance or you need to ask for a doctor's permission. Doctors are capable of giving really good advice if they have enough information.
Yeah.
But doctors do not have the obligation to know anything about massage therapy. And so if you go to a doctor and say, dear Dr. Smith, my client, Mrs. Whatever, has long COVID and she'd like to receive massage, is that okay? That is not enough information. And that doctor's okay or not okay is not going to help you work any safer or more effectively. So I'm working on a continuing education class about this as we speak, because it's a topic that just makes me insane.
Yes, and it comes up on a range of different conditions. I mean, we're not just talking about COVID related, that we have the same problem here, that a doctor will not recommend massage therapy because then there's a liability issue. But what they may oftentimes say is, I can't see it doing any harm. It's up to you. So it's very different. They're not. There's a difference between, like, say, ruling it in or out versus actually prescribing or recommending. And they're not going to do that, but they might well say, I don't see any reason why not, but I can't recommend it. Right.
But we could have another chat about this for another event, if you like, because there are so many ways that can go wrong.
Yes.
There are so many ways that can backfire. But I do want to make another point about your example of the person who has asthma. Right. Asthma occurs on a spectrum, and it can be really serious and not well controlled, and it can be extremely well controlled, and the person's a professional athlete. And this is why we do not rubber stamp conditions in massage, because the answer, is massage safe for this person, is always, it depends. It depends on things like this slide. It depends on the variables.
Yes.
All right. We'll move on now, because we really are coming on the end of our time. Okay. The next step that I like to encourage people to do is to challenge our assumptions. Are you sure you've really captured what your client wants to have happen? Are you sure you've identified the variables that are really going to make a difference? Is there another perspective that might help you get a broader look at this? And to go along with that, we need to consider our alternatives. So we can always fall back on what our hands usually do, but for special cases, it might be necessary to look at what other people have done. What does the data say about manual therapy and asthma? What does the data say about manual therapy and long COVID? I'll give you a hint, not much yet, but I would love to begin to see people gather that kind of information. But, it might be time to look at what other people have done, say with a client who wants to improve their migraines, to not have migraines, and your work does not appear to be making a dent in that. It's time to go and look at what other people have done for migraines, right?
Yeah.
And we plan and execute the session, and we think this out on purpose instead of by accident. So for instance, if your client has shortness of breath and they have their goal is to be able to walk out to their mailbox and back and not have to stop for a rest. Part of your plan might include some breath work, right? If their goal is to be able to stand up in their kitchen and make dinner for their family because that gives them joy, then your approach might be looking at neck and shoulders because they'll be looking down for a while. Whatever their goal is, you can translate that into your treatment strategies. And this is a part of the critical thinking rubric that I think most people, at least here, a lot of people leave out, which is to carefully and on purpose look at what works and what didn't work. If we don't reflect on results, we don't learn from what we've done. And, that can happen in writing, or it can just happen in a post-session conversation, or in, a phone call, or when you do your pre-session interview the next time. Because if we don't check back and we just assume that because the client rebooked for another session that our work is helping them, we're missing a great opportunity to learn more. So I really want to encourage people. And again, I want to say this little critical thinking rubric is something that can apply to virtually every client who has goals related to diseases and conditions.
Yes.
Hence, you could change it for goals related to athleticism, or goals related to
recovery from sports injury, or whatever it might be.
Recovery, whatever. But if we don't reflect on what we're doing and see if, challenge the assumption that it is effective, we're not going to learn. When we take all of this and we apply it as in terms of identifying risks and benefits for massage therapy for someone who has long COVID, the two main risks are, here's a person whose overall body systems are working very hard. And if they have long COVID that is fairly severe and that has involved heart and lung issues, and that they're dealing with migraines and brain fog and peripheral neuropathy, this is someone who's going to be easy to overtreat and overdo it. We also, again, for safety's sake, want to gather some information about the risk of coagulopathy, and I'll talk more about that in a minute. But those are the main risks. If we think about what we can do to be helpful, well, if this is a challenging time, what is more supportive than touch and careful attention, right? And as we've mentioned before, you brought this up in your thing about if the target is moving, this is actually a reflection of progress. It can be very hard for a person with a chronic condition, especially a chronic condition where we don't know about it, we don't know how long it's going to last, to feel very trapped by it. And if we can reflect progress, even the progress that involves picking up the phone and making an appointment for massage, that can be an impossible task, right? If we can reflect back on that kind of incremental success, this is a way we can be supportive to our clients. If we think about specific accommodations, right? What do we need to do specially for our clients who are living with long COVID? Well, here are some things. We need to rule out limiting situations like coagulopathy and organ damage to make sure that we're working safely. It is completely appropriate, with our clients' permission, to consult with their healthcare team, right? To see what their prognosis looks like, what kinds of treatments they're undergoing, what kind of meds they might be taking. If your client's focus and main priority is around being able to take a deep and unhindered breath, focusing on breath work is going to be great. We have lots of data on that for people with COPD and other breath problems. Emphasizing functional goals. This has been our recurring theme today. And something I really, really recommend for anybody who has a really severe condition, which is to work conservatively for incremental change. I'm not a big fan of magical get on the table with just a little bit of neck range of motion and get off the table and able to do like that, because that kind of change tends to backfire. I like to really recommend and encourage people to work for incremental change over time, because it gives the body a chance to incorporate this. Incorporate. Weave into the corpore, the body.
Yeah.
Right.
Totally get that. And you'd even see that where you talk about not overworking an already challenged system. I'd oftentimes encourage people not to do very vigorous treatment. You know, that is stimulating. And for somebody who's already challenged or compromised, it's overstimulating. That less is
can be. And then
more.
the consequence is they'll feel worn out and sore and, you know, overdone.
Overworked, yeah.
Yeah.
Because we talk a lot in treatment about the difference between intensity during a treatment versus pressure. A lot of people will equate pressure as intensity, and then sometimes use excessive pressure when, you know, you don't need to go that hard. You don't need to be hurting yourself and the client resisting and all those kinds of things, when you can have intensity without it being heavy pressure, or you can reduce the intensity and still maintain pressure. That those things aren't actually the same, but unfortunately they've become synonymous for a lot of people in our industry, that they are incorrectly I'm trying to think of the term. Conflating. That's what I was trying to think of. They're conflating those two when they are not the same. Interesting point.
Yeah, I agree. And one of the ways of talking about this that has come up in my article on fibromyalgia is the difference between pressure and presence. Right. And so if we are with a person who has long COVID or any other challenging issue, and they think they want more pressure, but what they really are craving is for us to touch them in a way that they can feel.
Yes.
You know, then an effective way to go about that is to go slow and have people, you know, breathe into whatever it is. I mean, there are all kinds of ways we can turn pressure into presence, and, you know, look at intensity in terms of focus rather than bruising.
Because we talk about area, angle, pressure, and pace is what we'd normally say is the things that contribute to intensity. So you can actually do something that's quite strong but slow, so they get that sense of, oh, you're getting to where I want to, but you're not overworking or overstimulating the system because it's slow.
Right. Yeah, give people a chance to incorporate. So I last year, actually, no, it was just the beginning of this year. I wrote an article for Massage and Bodywork magazine. That is one of our trade journals. And they make everything available to everybody. So you do not have to subscribe to this trade journal. And I wrote, it was called What You Need to Know About Massage Therapy and Long COVID, Unpacking the Long Haul. And, you know, it's dated now because it's 7-8 months old. But it's still got the majority of useful information. And one of the things I did in this, and so you can have this link, one of the things I did in this, Aubrey, is I created a set of screening questions, which we will not go through here because we really are on the end of our time. But it's a list of questions. For instance, please describe your activities of daily living, especially your physical challenges. And each of them is followed by, you know, a bit of a rationale for why this question is important and how it might apply in your session. One of the things is, have you been diagnosed with specific organ damage? Hang on just a moment. Do you notice any pain following physical activity? Chest pain or shortness of breath suggests cardiopulmonary problems, meaning issues with blood clots and heart issues that the client should discuss with their doctor. If they say, I can't make it to my mailbox and back because I just run out of breath, this is something that we need to pursue and ask them to describe what that's like. Because if they talk about a sense of heaviness or pain or pressure on their chest, that's more than shortness of breath. And that's something that, you know, needs to be referred out. May I contact you tomorrow to see how you are after your massage? This is going to give us a lot of information for that step 6 of the reflecting on our results.
Yeah.
All right. And that's what I have to say, we are at just an hour because we started at 8:09 my time and it's 9:09. So my gosh, we did it.
Excellent.
I did want to point people to where they can find me some more. So I am at ruthwerner.com. You can get on my mailing list. I send out a note to my subscribers probably every 3 or 4 weeks.
Yeah.
Maybe just talking about new things that I'm working on, or to share a today I learned thing. It's nothing very heavy, or it's, you're not going to get a big newsletter all the time.
Yeah.
I have a podcast called I Have a Client Who.
As educators, we are used to getting that question, Ruth. That's a brilliant name for a
well,
podcast.
send me your I Have a Client Who stories. Here's the I Have a Client Who story someone sent me. She said, "Hi, Ruth. I had a client today who is a nurse at the hospital where I work, and she just tested positive for tuberculosis." I saw those eyebrows. They went right up. And so she was like, well, she's going to go get an x-ray. We're going to get more information. I delayed my massage, but what do you have to say about massage and tuberculosis? So I did a little 10-minute thing on latent TB versus active TB and what it means to have latent TB, which is the situation for this person. And, we wrapped it up in 10 or 12 minutes. And that's the kind of story people send me. And it's really, really fun. And it drops every Friday. And you can get it at ABMP. ABMP is Associated Bodywork and Massage Professionals. That's the organization that publishes the trade journal that I do, and I do podcasts, and that's where I am found.
Yep. And just a note for Irish therapists, the IMTA, the Irish Massage Therapists Association, we actually organized to have a route for people to get membership. Typically it was that you had to have a combined thing and get insurance. They couldn't insure people outside the US, but we have managed to organize for a associate membership, I think it's called. So
that's great.
Students can contact, or therapists can contact the IMTA, and through that they can join ABMP, which is excellent resources across the board. I'd have to say, I've always been really impressed with all the stuff they do, including your Pathology podcast.
Thank you very much. I'm glad to know that. And of course, they publish Massage and Bodywork magazine, in which I am a columnist, and so is Eric from time to time, Till Luca, Whitney Lowe. All the cool people are there. So join us.
All the cool kids. I love that you put your book up there as well, because I'd really recommend to people, this is a must-have for every therapist. Like I said, the fact that the way the information is parsed is just so useful for therapists. The fact that there's that quick reference synopsis, and then there's the deeper, if you want to delve into what that condition really entails, there's excellent illustrations. Where can people purchase that? Where's the best place to get that, Ruth, if people are getting that book?
Yeah, well, you can get it directly from the publisher at booksofdiscovery.com. I am, not adverse to people getting it from the giant river in South America.
Yes. We've seen various editions there, yes.
Yeah, and that's totally fine, and maybe more practical in terms of shipping costs. And it's also available as an ebook, so you can. There's instant gratification there. Save on shipping,
yes. Save on paper.
Yeah, save on shipping, save on paper. That said, I often feel like I need to have paper.
I think therapists are just so haptic. They like to have a physical book, but the nice thing about the ebooks that I've always found is that it's accessible. Like you can be almost anywhere, and you don't need to cart around your library with you. And particularly for a book like this that you may want to reference spur of the moment, it's nice to have an e-version as well, so you can have it on a tablet or something and have a quick look before you go into clinic.
Yes, well, and I will add to that one of the benefits of being a member at ABMP is I worked with them to create an app, and the app is called Pocket Pathology.
Yes.
And it's basically what you just described. It's the quick reference, quick, very fast decision points for the kind of situation where, your client came in and said, "Oh, I have Guillain-Barré syndrome. That'll be all right." Right. And while they're getting undressed, you can quickly look up Guillain-Barré syndrome. So.
Yes, perfect for those situations. Because even as an experienced therapist, you do find clients will come in from time to time with a condition that you have not heard of. There's the standard things that you'll be well familiar with, but there's oftentimes those unusual cases that come up. You could be 15, 20 years practicing and somebody will come in with something unusual. And this is a great quick reference for that.
Good. Well, and the truth is, Aubrey, there will never be a textbook that covers all of the things or an app. Ultimately, it becomes our job to figure out what are those key points, what are the decision points. But that's not something we can do quickly while our client is getting on the table. That's something that might require a little more from us. But that's part of the purpose of that critical thinking rubric as well.
Yeah.
Yeah.
Well, that's good. Excellent, Ruth. I think you've managed to synopsize the information from that longer talk that you do, the 3-hour talk on this subject. And I think that's given people, like you said, the main points. There's always going to be areas that you can delve deeper into, which you do in your longer course. And I'd really recommend people who found this useful and would like to go into more depth to go ahead and do that course. Because Ruth, you have quite a few different education models available for people. You said you have, I was looking on your website, you have things that are like live workshops or live webinars, and then you also have pre-recorded stuff that people can access kind of 24/7, learn at their own pace.
I have a small handful of pre-recorded continuing education classes. They're just 1 hour. Now I don't ask people to sit with me for 3 hours and listen to a recorded thing. But I have a few, and I'm working on building out that library. And I am available to do things like this, to do live webinars, and I do them frequently. In fact, I'm doing one I'm doing 4 for the AMTA, the American Massage Therapy Association of California, over the next 4 weeks. And I work with several organizations in Canada, and I've done them in Australia. I've done them in New Zealand. So, happy to get around to English-speaking countries so far. And would love to do a live webinar through you or through the Irish Association. So let me know and we can maybe set something up.
So stay tuned, folks. You'll most likely find information. We'll be putting it out on our college website, which is hcd.ie. We're hoping to organize a live webinar with Ruth, and we'll have more information for you on that shortly. If you're watching this on YouTube or Facebook, we'll hopefully have this in our show notes and people can access stuff there as well. Is there anything else you'd like to add, Ruth, then? Because I'm conscious we're running a little over time.
Yeah, no, I'll just say thank you for a lovely visit. I have enjoyed my time with you and look forward to doing this some more. Thanks, everybody.
Excellent. I'm sure you'll join me in thanking Ruth for what has been an incredibly informative discussion, a nice starting off point. And I really like the fact that she said that a lot of her online modules are going to be an hour in duration. I know Ruth works a lot with Whitney Lowe, and I've discussed this with Whitney, the idea of chunking education to make it really easy and digestible. So I'm sure you guys will enjoy that. They're going to be really easy to follow. An hour isn't too much of your time. So do look up Ruth's additional online education. And for those of you possibly based in the US, they are going to have CEs and things. Certainly here in Ireland, you can claim things like that with your association and you'll get CPD points, which we'd call continuing professional development. So definitely a good route. So once again, thanks very much, Ruth. We hope to talk to you again soon.
Take care.
Thank you.